So my name is Dr. Patrick Kirwan. I'm a consultant psychiatrist and I work with an adult mental health team. So a psychiatrist is a doctor. So a psychiatrist, similar to someone's GP or a cardiologist or a surgeon, they have a degree in medicine and they've chosen to specialise in the area of mental health. So they've trained in managing mental health from a medical perspective. So psychiatrist is part of the community mental health team, and generally speaking their role is managing the medical aspect of a person's care. So usually, because mental illness can be quite complex and there can be multiple parts or components to it in terms of what maybe puts a person at risk of becoming unwell, or what causes a person to become unwell in this instance, or what keeps a person unwell. Psychiatrist essentially acts as the coordinator, the leader of the community mental health team. So the psychiatrist has a large role in, I suppose, the person's diagnosis, in your diagnosis, and in putting the overall management plan together. Now, the psychiatrist specialises in the medical aspect of a person's care, so sometimes there can be, I suppose, chemical imbalances that need to be corrected by medication. That can be an important part of managing a person's condition. So, you know, if a person is very anxious or very low in their mood, sometimes their mood is so low that medication is recommended. So the psychiatrist would, I suppose, first and foremost advise the team, the service user, such as yourself, about medication if it's indicated. But also the other parts of a person's care plan that might involve the other members of the team usually go through the psychiatrist as well. So usually, with mental health, we try to treat people in the community as much as we possibly can. Sometimes, if a person is unwell enough, they may require hospital admission, and the consultant usually is the first person, or one of the first people that a person will meet when they're admitted to hospital. So the consultant would be in charge of a person's care if they're an inpatient as well as if they're an outpatient. So my day-to-day job involves looking after patients both in and out of hospital. So on the hospital ward, or the mental health unit that I work in, and also within our day hospital, our community base that we work from as well, and where the team are most of the week as well. So I suppose in the outpatient setting, a patient might meet myself in a new patient clinic. So people usually see us via their GPs. So a GP might meet a person and have a conversation with them and feel like a referral to a community mental health team would be of benefit to their condition to help alleviate their distress. So if that happens, they would meet us in our clinic at a particular time of the week and we would do a full assessment. And as consultant psychiatrist, you will usually see myself at some point during that assessment process. So when a person is referred to us by their GP, they'll usually get a letter saying that you have been offered an appointment to Dr. X, Y or Z's clinic, and that's the consultant psychiatrist that's responsible for a person's care. So we also do what we call a review clinic. So that's for people who are well known to us. So people who have had their new patient appointments to us, they may have spent time as inpatients under my care. They mightn't ever have needed inpatient care, but in our review clinics, we would see them, I suppose, depending on how well they are. We might see some people every few weeks, we might see some people every few months, and sometimes if a person has achieved recovery, we might discharge them back to the care of their GP. That's what we always try and achieve. I suppose we would always try and help facilitate a person's recovery to the point where they might need the support of the mental health services anymore. They might have primary care services, they might have enough within their own family, within their own vicinity of friends, family, things like that. And some people, I suppose, might have more severe and enduring mental illnesses that need long-term follow-up, which we would provide for as well. So there's two settings in which you would meet me. So the first setting you might meet me in is if you have been admitted to the inpatient unit. Usually you will meet myself the day after your admission. So I suppose as consultants, we try to see our new patients or our new admissions as soon as we possibly can. So you'll usually meet a consultant within the first 24 or 48 hours of your admission to hospital, and they'll be a constant presence throughout your stay there. Now, in the community setting, usually on the first day when you come to the clinic, you may be reviewed by a consultant psychiatrist. You will meet the consultant at some point in your journey through the service. With the outpatient clinics that we run, there are a number of junior doctors in psychiatry who are under the consultant's supervision. So even if you are not being seen by a consultant on a particular day at a particular appointment, the consultant is a constant presence supervising who is seeing you. And every week there is a team meeting that's conducted where all the members of the community mental health team come together and discuss the clients that are under our care. So if there are any issues, the consultant is always made aware of them. So the junior doctors bring issues to the consultant as their direct supervisor, but the other members of the team bring issues to the consultant as well as the clinical lead. First of all, it's about trying to build rapport with the person, about getting to know you. Everybody's experience of mental distress is different. So it's about getting to know what the specific issues are with the person in terms of what's contributing to their distress and maybe what's keeping their distress going and why is this persisting for them. So I suppose first of all we talk to a person, have a conversation with them about what they feel the issues are. And then we would discuss with them, I suppose, first of all, if we're meeting someone for the first time, what we think is going on. Sometimes we might involve their next of kin, their support network, with the person's consent. So if we feel like it would be helpful to have more information or get a little bit more information from a person who is in this person's support network, we would do that. And then I suppose once we've gotten all of that information together, we would feed back what we think is happening to you. So I suppose we build up a list of things that we feel might be the issue here. We call it a differential diagnosis. That means things that we think this might be. And then we look at trying to eliminate the things that are less likely in terms of arriving at what we think is the primary issue here. And then we build a management plan for that. So there's usually two ways in which a person would access our service. So first of all, there's the routine way in which they might access our service, which is usually via a referral which is sent in to us by the person's general practitioner. So a person might see their GP with any number of, I suppose, issues involving mental distress, and their GP might decide with the person's consent to refer them to mental health services for further evaluation and potentially for further input if it's needed. So routinely normally means that, while the person does need to be seen, it isn't urgent. So that, I suppose, the other way in which a person might come in contact with mental health services is urgently. So that's if a person's distress is so great, or if a person requires input on the same day and it can't wait, that can be accessed via the person's local accident and emergency department. So there's usually a psychiatrist on call, or there's sometimes nurses, mental health nurses who are specialised, who work in the accident and emergency department as well, who can see a patient if they present. Now, sometimes a person might see their GP and the GP might think that they need to be urgently seen, so they might write a person a letter to bring with them to the accident and emergency department. And sometimes people might arrive without a letter, which is fine, so a person will still be seen. And so following a discussion with the patient, similar to any other encounter with the mental health professional, the person is given space to talk about how they're feeling, and a plan is put together in terms of helping to alleviate a person's distress. So presenting to the mental health services urgently doesn't always result in a hospital admission. Sometimes a conversation and I suppose a slight change or an alteration to their management plan can be effective. Sometimes if a person's distress is particularly high, a hospital admission might be indicated, but we would always strive to treat people in the community as much as we possibly can. One of the things that pushed me towards psychiatry, or interested me in psychiatry, was as a medical student seeing people who were unwell and seeing the difference between, I suppose, a person who was in the throes of an episode of mental distress and then seeing the contrast between that person from the point of entry to the service versus their point of exit from the service, and just seeing the contrast between how the person was in both of those instances was just something that was extremely rewarding from a professional standpoint, and was definitely what drew me towards psychiatry in large part as a student, training to be a doctor many years ago now. But so what I would say to people is psychiatrists will challenge you at times, but the psychiatrist will work with you. The psychiatrist is there to help facilitate recovery, to help a person discover and, I suppose, draw from their own resources to achieve recovery.